The word laser is an acronym for light amplification by stimulated emission of radiation. E1 is an atom which is already in the energized state. Now it absorbs an additional quantum of energy and in turn releases two quanta of energy. These two photons are in phase with the stimulating photon, causing an amplification of energy. The two photons that are in phase now stimulate nearby atoms which are already in an excited state, setting off a chain reaction of stimulated emission and creating a laser. Laser iridotomy is now the procedure of choice for all forms of angle closure glaucoma in which there is a component of pupillary block. Nd:YAG laser and argon laser are used for this procedure. However, in situations with markedly thick iridis, we found it necessary to supplement Nd:YAG laser in iridotomy with either the argon laser or the frequency doubled Nd:YAG laser. The active medium of Nd:YAG laser consists of neodymium atoms embedded in yttrium aluminium garnet, in short, YAG. The YAG laser is pumped by a gas discharge lamp and has a wavelength of 1064 nanometers. It can be operated in continuous wave mode for its photocoagulative property. The pulsed Nd:YAG lasers are high-powered lasers that are photodisruptive and are used in iridotomy. Pulsed Nd:YAG lasers may be Q-switched or mode locked and are the two principal means of compressing the laser output in time to achieve high peak power. The high irradiance ionizes molecules in a small volume of space at the focal point of the laser beam, disintegrating it into a collection of ions and electrons called plasma. The plasma expands rapidly, producing shock and acoustic waves that mechanically disrupt tissues adjacent to the region of laser focus. Laser iridotomy is a safe, effective, and preferred alternative to incisional surgical iridectomy. The indications for laser iridotomy are primary angle closure glaucoma, aphakic or pseudophakic pupillary block, anatomically narrow angles and signs of previous attacks, incomplete surgical iridectomy, luxated or subluxated lens, nanophthalmos, malignant glaucoma, pupillary block from silicone oil after vitrectomy, mixed mechanism forms of glaucoma, pigment dispersion syndrome to eliminate reverse pupillary block. Laser iridotomy is an outpatient procedure which can be performed under topical anesthesia. Two types of lasers are commonly used for iridotomy: the Q-switched Nd:YAG laser and the argon laser. The Q-switched Nd:YAG laser is preferred by many surgeons because it penetrates the iris easily. It is difficult to penetrate dark brown iridis with argon laser because they have a tendency to char during treatment, and light blue iridis can be difficult because pale iridis do not absorb laser energy very well. As the pulsed Nd:YAG laser has no coagulative effect, bleeding occurs more frequently. Meiosis helps tighten and thin the peripheral iris, pulling it away from the cornea, and can be accomplished with pilocarpine 1% or 2% eye drops. Do not start shooting the laser when there is pupillary reaction. Aproclonidine 0.5% eye drops may be instilled to reduce the magnitude and frequency of post-laser intraocular pressure spikes. An Abraham iridotomy lens is used during the procedure. It consists of a corneal contact lens with a plus 66 diopter plano-convex lens button placed on its anterior surface. This lens improves visualization, ensures lid separation, stabilizes the eye, minimizes epithelial burns acting as a heat sink, and increases the power density by concentrating the energy into a smaller spot size at the iris. The iridotomy should be placed in the periphery of the iris to reduce the likelihood of lens injury and subsequent sealing of iridotomy by posterior synechia to the lens. A site between 11 o'clock and 1 o'clock is preferable, as it would help minimize glare and diplopia. In the presence of a dense arcus senilis, the iridotomy site must be central to it. Avoid the 12 o'clock meridian because gas bubbles can rise to this area and obscure the laser site before treatment can be completed. Identify a thin region in the depth of a crypt or in an area evidenced by a rather lacy, transluminant appearance of the superficial stroma. Careful focusing is critical. You can ensure this by seating the patient comfortably, taking care that the forehead is in close opposition to the forehead rest and the chin is in close opposition to the chin rest. Introduce the lens and ask the patient to look down in the direction opposite to where you will be aiming the laser beam. Now, aim the laser beam onto the superior and peripheral part of the iris. Focus the 4 spots of the helium neon beam, manipulating the spots until they merge into one spot. In case you do not achieve the beam as a single spot, move back from the oculars and check the position of the patient. Ensure that the patient has not moved the chin back in trying to look down, for then it would be impossible for you to focus the spots into a single beam. The greater the energy you use, the greater the forward movement of the shock wave. Since the shock wave travels towards the surgeon from the point of focus, it is helpful to have the focal point within the iris stroma. For this, one has to focus the laser beam precisely on the surface of the iris and then use the posterior offset option, making it converge 0.1 mm in the iris stroma. The endpoint of the procedure is the mushrooming of the pigment into the anterior chamber. As media opacity and induced astigmatism can degrade an otherwise predictable optical breakdown, try to avoid corneal scars and arcus senilis. Also, make sure that you avoid distortion of the laser beam by aiming the beam perpendicular to the contact lens. Improper focusing will lead to swelling of the iris stroma, after which penetration will be impossible no matter how much one may increase the energy. Since the shock wave propagates towards the surgeon, endothelial damage can occur when the chamber is very shallow. Enlarging an ND-YAG iridotomy is considered hazardous because of the risk of lens injury. By avoiding focusing the aiming beam into the depth of the crypt, we have been able to enlarge iridotomies when needed without any obvious lens injury. If ND-YAG iridotomy fails, repeat treatment can be directed to the same site in 2 or more sittings. Argon laser can produce contraction burns called coagulative effect with low energies at longer exposures and can produce penetrating burns called explosive effect with higher energies at shorter exposures. Argon laser is used when the iris is unusually thick or when one anticipates hemorrhage during the procedure. The tissue reaction to argon laser varies depending upon the amount of pigmentation. First, place contraction burns at the proposed site of iridotomy to achieve stromal thinning. Then use penetrating burns to chip off the iris stroma. Now, make the opening in the iris using 1 or 2 shots of ND-YAG laser. The complications of laser iridotomy are iritis, post-laser intraocular pressure spikes, hyphema, closure of iridotomy site, corneal endothelial burns, retinal burns, and cataract. In this video, we have seen the use of ND-YAG laser for iridotomy in the treatment of angle closure glaucoma. Understanding the principles involved in laser iridotomy and a timely diagnosis will help us treat a large number of angle closure glaucoma patients.